was 2 a.m. when the paediatric alert bleep went off. The intensive care registrar and paediatric registrar both rushed to the emergency department. They arrived in resus at the same time as an acutely short of breath 4-year-old girl. The intensive care registrar examined the child. The paediatric registrar spoke to the mum, because that's how we do it, and the nurses put the monitoring on. After a few minutes, the paediatric registrar and intensive care registrar arrived at the bottom of the bed, and they had a chat about what should happen next. It's not always clear what the right thing to happen next is, and people disagree. And they disagreed, and it's disagreement in a fairly high-stress situation. Voices got raised. There was a little bit of, I really think this, I really think that. And then eventually the will of the paediatric registrar prevailed. And what they decided to do was go for maximal medical therapy. That means that they weren't going to intubate and ventilate the little girl there and then. The intensive care registrar said, that's fine, I'm going off, I'm going back to the intensive care unit. I have other patients to see, but I'm coming back. It's okay, I'm coming back. And the paediatric registrar started trying to get a cannula, an IV line into this little girl's arm. And the nurses said, what do you want us to give next? He said, aminophylline. They had a quick chat to each other, and then they came back and they said, how do you make it up? Because this is an adult emergency department and they don't have paediatric nurses on overnight. So how do you make it up? He said, I'm a bit busy, you're just going to have to go and look it up because you make things up differently for children than for adults. So they did. They went away and they made up the aminophylline. And that probably took them about 10 minutes, and they came back. And they said, what rate do you want it to go at? And he was really struggling. He hadn't got a line in yet. If you can imagine, tiny, tiny little needle into a tiny, tiny little vein in a child that's not well. And he was really struggling. They said, what dosage? And he turned around and said, for God's sake, just leave me alone. I need a minute or two. And they did what any of us would have done at that moment. They stepped back. They stepped back and they waited. And what happened next was that he actually did get the IV access. That's kind of unusual. Usually when you've had that kind of outburst, that's not going to happen, but he did. And he then wrote up the dose, and we connected the aminophylline through the pump, through the tubing, into the little girl's arm, and over the next 20 minutes delivered 16 to 20 hours worth of aminophylline, which is a very toxic drug. There was, of course, a datix, an incident form, and there was, of course, a root cause analysis. And at the end of our root cause analysis, what did we find? We found that the nurses were not competent, the nurses needed to go on more training, the nurses weren't allowed to give any more medications until they had proven themselves to be competent. And I think we missed the point. And I think we pretty much guaranteed that in the same situation, the same thing would happen in the future. So for the last 10 years, I've been a governance lead, investigating and trying to understand situations like this one. And there are some things that have become clear to me that healthcare is a team business. That's not rocket science. But we deliver it in complicated, sometimes complex environments, and we do it with varying outcomes. But if 10 years ago you had asked me what the answer was, to me, I'd have been really clear with you. I'd have looked you in the eye and I would have said, the answer is process. If only everybody did what they're supposed to do. But there's a problem with that. Because you can only tell yourself that so many times when you're actually dealing with people that you know, you respect, you trust, never mind whether or not you like them. You can only tell yourself that so many times before you think, how come all these people that I know are really good get involved in errors? And what I came to realize over time was that actually your process exists in an environment. The environment determines how well we can do process. And I simply wasn't respecting the complexity of the environment within which we try to discharge our duties as healthcare professionals, or any professional. And so for me now, when somebody asks me what I think the answer is, I still think that process is important. It absolutely has its place, but something else is more important for me. And that's people and how we treat each other. And I think the evidence bears me out on that. But just for clarity, I'm really not here to talk about the avoidance of error. The avoidance of error is well and good and it's important. I'm really here to talk about how we set ourselves up to win, how we actually set ourselves up so that we might aspire to excellence and not just avoid the bad stuff, because they are slightly different processes. So what I'd like to talk about next is complexity. And we all know that we work in a complex environment, complicated, complex environment. But I'm not sure we can always actually really describe that. We have a feeling for it, but without a description. I'm going to do something that you're not really meant to do, which is create a graph in a talk. Creating a graph in a talk is regarded as being a bad thing, but it's your punishment for making me have to talk just after lunch. So let's see what happens. This graph changed how I think about my job. And it's by a guy called David Rook. David Rook is a management consultant who has one of Harvard Business Review's top 10 downloaded leadership papers called 7 Transformations of Leadership. And the graph will build up over a little while, so maybe over the next 5 minutes or so, start building it up. So here we go. Do we agree what the problem is? Do we agree on the solution? Sorry, I'm getting in the way a wee bit. And then to make the graph just a bit more ugly, we'll put the high points down at the intersection. But it begins to explain itself very quickly. Simple puzzles. 2 plus 2. Everybody in this room knows what the problem is and you know what the solution is. Hard puzzles. Sudoku. I don't know how to do Sudoku. If I wanted to learn to do Sudoku, somebody would need to teach me. And then within that, I know that there are simple ones and really hard ones. Complicated. Complicated is a liver transplant. There are lots of people heading in the same direction, but they all have their own problems and they all have their own solutions within that direction of travel. And then finally, there's complex. Now, complex is Syria. Lots of people think they have the solution to Syria, but there are lots of different solutions depending on your perspective and what you see as the problem. Within healthcare, the classic example of a complex problem is the 4-hour target. And most organizations could achieve the 4-hour target, but to do that, they would have to sacrifice a whole bunch of other very important things like having elective operations, and people coming in for cancer therapy. But what do we test? Well, we test simple puzzles and hard puzzles. When you went to school, simple puzzles, hard puzzles, college, university, simple puzzles, hard puzzles. Stuff that you and I can be tested on one-on-one. But as leaders, where do we get our results? And everybody in here is a leader. Where do our results come? Do they come in simple puzzles and hard puzzles? Not really. For most of us, our results come in the complicated and complex zone. And that's difficult because we don't really know how to test people on that. We have a feel who's a good leader, who's not. But we can't really test it. In medicine, the closest we get is we run simulations, and that takes us up into complicated a little bit. And here's the lemon I was sold, and that I bet a bunch of you have been sold. I was told that when I went to university, And I got my degree. I become a doctor. I started to be able to tell people what to do. It sounded good. And then I become an SHO, then a registrar, and then I would go on from there to become a consultant. By the time you're a consultant, then you can really tell people what to do. You tell them what to do and they do it. And it's that model of autonomy that belongs in the 1940s and 50s. That's what medicine looked like. And I genuinely thought that when I became a consultant, I would be able to tell people what to do and they would do it. And they don't, for very, very, very good reasons. So a couple of things happen as we go up this graph. And the first is that as things get more complicated and complex, we need a team. We can't do it on our own. It's not possible. And there's something else that happens. As we get up into complicated and complex, we stop being clever enough to see it all. I am married to a Welsh Bangladeshi Muslim woman, and who spends a lot of money. To be fair, it is her money, it's not my money. I just have this anxiety that we won't be eating for a little while. And it doesn't matter how much I think I can see the world. I can't see the world through her eyes. I don't have her experience. I don't have her understanding of what it's like to be in her position. So, as we get up into complicated and complex, how do we find out what other people are thinking? Any thoughts? You ask them. And then you listen. So it's not just the asking. The listening part is obviously key. And what that means is that we come into these problems and we think we know the solution. But as we ask and listen and reflect, and this is me in trauma management, or me running governance in the department, as we ask and listen and reflect, we begin to see further. We begin to see different things, and we begin to need to do something else. And the thing that we need to do is compromise. And I wasn't sold that idea. I was told that when I was the boss, I would tell people what to do and they would do it. And compromise wasn't really in there. But for complicated and complex stuff, if you don't compromise, you're not listening. And there's an argument that what I'm arguing for here, up in the complicated and complex zone, is for equality and diversity. It sounds like a veiled argument for equality and diversity. I should unveil that. I think it's a very clear argument for equality and diversity. And not just amongst us in the team, but also for listening to the voices of the people that we are there to serve, our patients. So what do people do to make complicated things understandable? Simplify them. In fact, everybody does it. We all do it. And we're very guilty of it. It's measured. There's science around this. And I don't know if any of you guys have ever had a new manager come in who doesn't actually do your job, come into your team, comes along and tells you how to do your job and how to fix things. And I think many of us will have had that experience of somebody coming into our teams who doesn't understand what it is that we do and thinks that they come in, they've got the answers to our problems. It's staggering arrogance, but it's actually very common. And it's kind of how they get the jobs sometimes, because they get interviewed and they say they've got the solutions. Now, that's research. David Dunning and Stephen Kruger researched this stuff. And this is their graph, or a version of their graph. And it's basically, how confident are you versus how experienced are you? Not how good are you, but how experienced are you? And there is a peak. There's a peak up here. And there's two things I really like about this graph. The first is, you probably can't read this, down the bottom it says know nothing, NO. And the second part is that very occasionally, and it is occasional, up here, this is referred to as Mount Stupid. And Mount Stupid is the place where we find ourselves when we think we understand somebody else's world, when they're actually an expert at it. And we think that we can tell them what to do, how to make things run a wee bit better. And I find that interesting because it has made me stop and think, particularly when I'm doing investigations. Many years ago, I thought I knew the answers. Now I just have more and more and more questions. The only answer I really think that I have is that people were doing their best. So that bit is really just a plea for respecting complexity, being able to understand it or describe it a wee bit. But I've already said we deliver care in teams. And you guys, have you ever had Michael West along to talk? Yeah, I love Michael West. Proper middle-aged man crush. It was once pointed out to me that I had Michael West's picture 5 times in a presentation. But he's a good-looking man. You know, what can I say? When I'm a grown-up, I want to be like Michael West. His beard is just too squat. What makes teams good? And, you know, up until a few years ago, the absolute best evidence we had on this was from Michael West and within healthcare. And that massive data set stuff he does when he talks about things like, just to give one example of it, are you in a team? Yes, we all think we're in a team, but are you in a team or are you in a pseudo team? And the difference is a pseudo team can't describe what they're trying to achieve. A team can describe what they're trying to achieve. And about 60% of us, I think, although 95% of us think that we're in teams in the NHS, about 60% of us are in pseudo teams. We can't really describe what it is we're trying to achieve. And that's interesting in my world. And it's interesting in my world because there is a clear and obvious tension in my world. And that is that, what do I come to work for? I go to work to deliver the best care that I can within the constraints of the department and the time that I have to the most people. It's not just to one person, it's to the most people. What do my organisation want from me? Or the middle managers within my organisation? What are they being measured on? They're being measured on breaches, 4-hour breaches. Now, sometimes good care and 4-hour breaches are in the same direction, the avoidance of 4-hour breaches. But often they're not. And in really tense systems, they're frequently not. And what we end up with is a bunch of people aiming in this direction for the 4-hour target, and a bunch of people aiming over here for the most patients treated in the best way possible in that period of time. And if we don't describe that, if we don't discuss that, what happens is that space in between them becomes tension between us. And that tension in a really difficult environment becomes unpleasantness, hostility, fighting. And then we simplify it all in our heads. We make all, you know what, just a bloody manager. Or just a bloody awkward clinician. And the consequence for us is it really can genuinely rip apart teams and departments. And in the case of mid-staffs, where I was a decade ago, it rips apart whole organisations. And in fact, mid-staffs doesn't exist anymore. And the biggest tension in mid-staffs was that people didn't speak to each other. They didn't listen, they didn't understand where people were coming from, and there were no baddies. Despite how much everybody wants to say that, you know, the management were baddies or some of the clinicians were baddies, it's not true. These were good people doing what was asked of them, all of them. But they didn't talk and they didn't understand why they were ripping apart, and then they made a really simple narrative solution for themselves that each other were unpleasant and useless, and they didn't like them. So anyway, Michael West, tons of work on that. Really great work, love it. Then, about 3 years ago, and you've already heard this mentioned a little bit, a couple of people called Riskin and Erez did something that we as doctors really like. They did a randomized controlled trial. And they did a randomized controlled trial of paediatric teams going into a peri-arrest situation with a child, but they matched the teams for expertise. So instead of just having individuals and having that you being measured in the simple puzzle, hard puzzle zone, they started to take it up into complicated as a team. And what did they find? Well, they found that we grade on a curve. Some of us in the same situation in our teams of 4 will have the catastrophic outcome, and other ones will have the truly excellent outcome, the thing that we all aspire to. And what they found was that 40 to 60% of the variance in there could be explained by one thing, because these were all competent teams. And the variance was explained by rudeness, incivility, and how we treat each other. And it turns out that as the evidence stands at the moment, if you're competent, the single greatest factor in terms of how well your team will perform is how you treat each other, which is a little uncomfortable, particularly if you were brought up in the 1980s medically in Edinburgh, where treating people well was perhaps not top of our agenda. So incivility. If it's such a big deal, how come? I went to medical school, it never got mentioned. I did my membership exams, not mentioned once. I did my fellowship exam, nobody mentioned it. And the answer to that is really simple. It's new science. Between 1996 and 2000, there were 23 papers in the whole of the academic literature on this. Between 2011 and 2015, there were 1,700. And they all say the same thing. This stuff counts. So I should ask, have you ever seen rudeness at work? Now, you've already been asked this today. Have you ever seen rudeness at work? Yeah, I'm getting some no's. Because maybe it was to you. Maybe it was somebody near you. Or maybe it was by you. And it has absolutely, certainly been by me. How did it make you feel? You wrote this down, and I wonder what you wrote. My guess is that a bunch of you were angry. And it's interesting because we remember the anger. But if you look at the work on this by Christine Porath, something else happens first. In the moment when we experience this directed towards us, we feel belittled. We feel ashamed. We feel humiliated. We sometimes think, perhaps I'm just not cut out to work here. Maybe I'm too soft to work here. Maybe I'm just not the right sort of person for this organisation. And in the moment, we feel like children. We feel less. And then slowly, over time, we process that. And the way that it ends up being processed for 95% of us is that are there many doctors in here? Any orthopaedic doctors? No. Excellent. Richie, you might need to explain this next slide to people. Okay, so 95% of us have not even started. Listen, I study this stuff all the time. I'm a ninja. This is how 95% of us respond to it. We get angry and we want to get even. The interesting thing about that is that it's emotional. It's an emotional memory. Now, I get the BMJ every week because I'm in the BMA. And I do something that many other people who get the BMJ don't do. I open it. I open it up and I read a bit of it. And I read the front bit and I read the stuff that tells me really smart stuff to know about from other journals. I read that, I like that bit. And then I go to the obituaries. And when I get to the obituaries, I look down them and I see young people and I feel sad about young people who have died. And I look at the picture that's on there of the the person who had the massive impact in the world. And I look at that and I go, oh, God, that's incredible. What an amazing thing they did. And then I just skim down through the other ones. And every so often, I come across somebody who educated me in the 1980s in Edinburgh. And every so often, I look at them and I remember them. And I can't remember much about them, except for I have this feeling when I see that they have died. And the feeling that I have, and I'm not proud of this, is yes. Because we retain that emotional memory of people who treat us like crap. People who make us feel like less. We retain that emotional memory. And here I am, 30 plus years later, looking at them and feeling something resembling pleasure at their death. What is that all about? But that is us as human beings. Hope it's not just me. It's not just me, though, because I saw the nodding head, and I'll be coming to speak to you, nodding head person, afterwards, to say thank you. I'm not looking in your direction. I'm not looking in any direction. So, just to go through a little bit about the evidence behind the real hardcore evidence about what happens to us in those moments when there is rudeness. There are 4 distinct groups that experience rudeness. I'm only really going to talk about 2 of them just now. And it probably helps to mention very briefly, I'm going to talk about bandwidth. On a good day with a falling wind, you're pretty smart guys. You can deal with 5 to 7 things, and you can play with them in your mind. You can come up with creative solutions with them. However, we're busy. We're busy people. We've got houses, cars, more cars, relationships, bills. So by the time we get to work, we're dealing with 3 or 4 things. And that's pretty good. You can still do a lot of stuff with that. And that's our bandwidth, and it can open and close. What happens to people who receive rudeness, the recipients of rudeness? And for clarity, when I'm talking about this, but I am not talking about somebody screaming in your face. Okay, I'm not talking about that level of rudeness. That level of rudeness, we probably have all seen it at some point. For the recipient, that is utterly overwhelming. In fact, it overwhelms us so much it drives us into a state called freeze, when we just stand there and we can't do anything because we are so shocked. It's mediated through amygdala overload. And if you've not seen it in real life, you've probably had it in a dream, when you were rooted to the spot in a dream when you were so scared you couldn't move. I'm not talking about that. I'm talking about mild to moderate rudeness. You come and chat to me afterwards and say, hey, Chris, really nice of you to come up from Birmingham. Pleasant to see you. That's 45 minutes of my life I'm never going to get back. It's not awful. We say worse things, or at least we do in my department, but it feels a bit crap, and please don't do it. Okay? So it's that kind of level, mild to moderate rudeness. It's not nice stuff, but it's not overtly hostile. On average, in the moment when that happens, we reduce the person receiving it, we reduce their working memory by 61%. We close down their bandwidth. In the moment, we make people less. When somebody is rude to you in the moment and you don't see it coming and it's not safe, you are less than you are the rest of the time. And that is why, when you get in the car and you're driving home and you stop at the lights and you feel safe and you know the lights aren't going to change for another 2 or 3 minutes, you relax and then you think, damn it, that's what I should have said. You think that there and then, because then you're back to being you. You're back to being the wonderful, smart, creative version of you that thinks of witty things and has the comeback on hand. In the moment, we don't have it. And in fact, if your self-esteem is so low that you want to make yourself feel better, and by that I mean feel cleverer than the people around you, this is a brilliant tactic. Because you will humiliate people, you will make them less in the moment, and you will feel better about yourself. And most of us know people who use it for that reason. But what about the impact on staff onlookers? Because we've already mentioned this a couple of times earlier on. So I am reminded of a story from my own past. I'm in the emergency department. It's in Coventry. It's busy, really busy. My colleague has tried to refer a patient on to the neurosurgeons. And the word neurosurgeon always gets somebody going, and I really like our neurosurgeons. They're good guys. They're there. And the neurosurgeon that's on is a really good guy having a really bad day. Really bad day. My colleague has tried to refer a patient who he needs to see. He said no. I go and speak to him and say, got this patient, maybe we've got wires crossed, but I think the patient, you need to see the patient, she needs your help. He says no. I step up my intervention, got this patient, really needs your help, really needs neurosurgical help. Neurosurgeons, you guys are really special, and if I'd been clever enough, do you know what I would have wanted to be? And he said no. And I kind of run out of tactics. I don't have a lot of tactics, and that's me kind of running. So, and I'm getting a bit hacked off. So I decide, in my wisdom, that I would drop the C-bomb. I said to him, I need you to see this patient because she needs your help, and I am telling you because I am the consultant. And he looked me in the eye, and I looked him in the eye. There was a lot of eye looking going on. And he said to me, what do I care? I'm going to be a consultant someday. And I'm standing here in front of you, right here, right now, to tell you that the red mist can descend from the Pentland Hills, just outside Edinburgh, all the way into Coventry in about half a second. And as I stood there, and my voice got deeper and more Scottish, and slightly more hostile, West Coast, and I drew myself up to my full 5'7.5". I saw two things happening. The first was that my wonderful, fantastic, amazing nursing colleague came round from her desk and she was coming towards us because she, quite rightly, wasn't letting this happen in her department. And the second thing was this. I started watching the heads go down. It's about a 4 metre square that we stand in, and we can have up to 30 people in there. And the first head went down, the next one, pop. Then the next one, pop, 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 pop. All these people's heads going down all over the place. And I was convincing myself that they were going back to work. All of them, heads down, head down, head down, head down, head down, apart from you. 3.5 metres away, looking across. And in my head, I know his head didn't go down, but in my memory of this, he's opening a packet of crisps and getting out a can of Coke because this looks like fun. And I thought these people were all going back to work, and they kind of were. And my guess is a bunch of people in the room will have recognised that syndrome when you have a fight with somebody and everybody just puts their head down. But actually, there is a direct impact on their cognitive ability. And on average, these guys have a 20% reduction in performance. But it's worse than that, because it's actually contagious. And if they get up and they are going to go and speak to somebody around the corner, they go around the corner and somebody asks them for help, just a straight request for help, they are 50% less likely to help that person than they would have been if they were not primed by being near this behaviour. In fact, if you prime healthcare professionals with rudeness and then you get them to check a page of calculations, drug calculations, they miss 50% more errors because it messes with our bandwidth. It stops us being creative and stops us being able to think through stuff. The other groups are patients, the most important group in many respects, and the team leaders, but not quite got enough time to get into that just now. There is one group of people, though, who are more likely to be rude than any other group within healthcare or outside healthcare. And that's bosses or people in positions of authority. And they don't start like this, but once these people become bosses, if you're a boss, you're 3 times more likely to use your iPad, for something other than that meeting when you're in a meeting. You're 3 times more likely to interrupt somebody, and you're 3 times more likely to raise your voice at somebody in a meeting. There's all sorts of experiments around this, but we change. We change when we become bosses. We are permitted to behave in different ways, and unless somebody tells us that the way that we are behaving is causing other people distress, we don't know. Behaviour rarely self-corrects. If anything, it tends to become a little bit more extreme and a little bit more extreme. Okay. 1959. The NHS is 11 years old. It's Western General Hospital in Edinburgh. That's my mum. And that's Julie, and that's Charlotte. That's our pals. My mum still goes for coffee with Julie and Charlotte when they're around. These women were forged as nurses in the NHS, and they have carried this through their whole lives. And on the wards, my mum is suggesting to patients that perhaps they would like to go outside for a cigarette. It's good for the nerves, you know, because the doctors are telling them, the patients and the nurses saying, go out for a cigarette, good for the nerves, calms them down, get them back in again. In fact, and this is me being my mum, if you don't smoke, maybe you'd like to think about taking it up. And then we found out the terrible toll that tobacco takes on health. And we changed. We simply changed. Now it's 2018. We're beginning to understand the impact that behaviours have on teams, team performance, and each other. That's great. What a wonderful opportunity. Because by choosing to behave in ways that value and respect the people around us, we help each other to hit our own peaks. When we do that, we help the team to hit its peak. And then we have the best outcomes for us, but also for our patients. Or in other words, civility saves lives. Thank you very much.